I'm going to tell you a little bit about this project, EPOC, and it's the greatest type of talk to give, which is it's a total promissory note, right? I mean, there's no results, there's actually no work that's actually been done, and the grant's actually already been written, and as Majid said, it got scored very well, so I think it's ideal. So let me jump into this in a couple of ways. So first is I'm going to give you the structure of how I think, and at least my story around how it all came together. Really, I think it emphasizes so many points that are really critical to, I think, what Majid's trying to accomplish here, which is, I think, very special and very unique. It's a big idea, right, to take us away from kind of the roles that we oftentimes have in our own research and work, and to try to think about the interconnections, right, the complexity of the entire system that we all operate in. And so, really, in this order, I think I'm going to try to go through things, and there are a couple of busy slides that I'll probably just pass over. Mostly it was for information within your packets and stuff if you want details. Let me start with this idea of collaboration, and this is something that, I think, Majid's mentioned before. This is a very unique grant in the sense that it really did break us out of our unique patterns. But what it did was it really leveraged and built on individual strengths. I mean, there's the clinical expertise from multiple different groups. There's also the population health expertise from the folks at RAND. The grant really did build a lot off of the Medical Control Authority assessment project that was just described, and it also built off preliminary data in a lot of our other research groups too. And so I think with that foundation, it was just so well suited, I think, for this particular question that we were trying to address. And then, as she said, it got scored, and I keep telling her it's actually nothing better than almost getting funded, because that means you have another 6 months of just waiting time, which is good, and don't have to start. So I don't have to explain this to a lot of folks in the audience, but I mean, this is kind of this is like the health services research template, right? Big problem, a lot of people die, costs a lot of money, and we have no idea why some people do super well and other people don't do well. And this was really emphasized in the IOM report. Bob Newmar was a part of that. I was a part of this. This was put out a couple of years ago, and it really forced this idea of this template of, we do need to start thinking about game-changing differences in terms of how we really tackle this important problem. All right, so the way that we started to kind of tie this in was when we think about conceptually how people look at the very far right over there about outcomes, right? Why do some people do better? Why do some people do worse? It really is a very complex problem. In fact, out of all the acute care problems that exist, I mean, you can't get more acute care than this, right? Someone's heart rhythm or, for whatever reason, blood pressure collapses, and you've got to act really quickly. But it's a very difficult problem to really tackle. There's obviously patient and community factors. There's factors around the response system. There's responses even that matter once you reach the hospital and the care around that. And what's fascinating about this is there's been a lot of work in all these little individual silos, right? So we do know a lot about how patient factors and community factors play a role. Bystander CPR is actually one of the most powerful predictors of good outcomes. We also know at the other extreme hospital factors that might play a role, right? So if you have early access to angioplasty, if you have cooling of these patients afterwards, that might play a role. But a couple of gaps that we've noticed in the literature are that the EMS agency, surprisingly, has been really absent from a lot of evaluations. And furthermore, not only is the EMS agency absent from a lot of these discussions, the interdependencies of this entire system have really been unexplored. And I think it gets to the heart of what is a fundamental problem in health services research. We oftentimes answer the questions that we can answer, right? Someone's got a database that involves patient and community factors, we'll look at that. But we don't tackle the questions that are actually important and hard. And I think that's why this has been a fundamental shift, is these kinds of conversations and talking about that is a really critical role for moving ahead. So we thought, let's focus on the EMS agency as a link, but not ignore the surrounding sites on both the earlier and post resuscitation care that occurs. So there's a reason why people haven't tackled this, because complex systems are just tough to understand. I think anybody who's worked in this space knows how difficult that can be. Big problem, big challenge to solve. So what we started to do was use an approach that we've used before, which is mixed methods work. And mixed method studies are really, I found them very exciting and fascinating. I'm a quantitative person by training. That's what I kind of, understand and really, I think, do probably better at. But I've just been fascinated with some of the qualitative data that we've kind of collected on recent studies. And it really does allow you to have a deeper understanding of why and how, and not just what. I mean, as an example, I'll talk a little bit about in-hospital cardiac arrest, but I mean, we spent a decade analyzing every single XY association you could possibly understand. And yet, visiting a few hospitals, I've had an eye-opening in terms of like actually what happens on the ground floor. It also is a really unique way of thinking about things holistically. And there are examples within our group where we've kind of tackled this. Lots of different researchers, some of them in this room, who've been very involved with a lot of these studies. The last study, the heroic study, is what was, for me, an eye-opening idea. And again, for a decade, we published a number of papers, some in the highest tier journals, just talking about how hospital performance in in-hospital cardiac arrest, so you have the cardiac arrest, but you're already hospitalized, and how you do. And so we, again, started to say, well, why don't we go and visit some of the hospitals that keep doing better than others and see what's going on there, and then visit the ones that are struggling as well, and perhaps understand this. And this has been a framework for us. But I will say what's really fascinating about what she came, and when she started to come up with the idea of like, well, why don't we do this in the out-of-hospital cardiac arrest setting, I was like, well, hospital you can go to, right? I mean, how do you find an EMS agency? How do you bring all those people? So this is a bit of a game changer in my mind, the EPIC study, because of the challenges of what it's trying to accomplish. So as usual, she came up with this acute care continuum approach as the framework for it. And when you think about it, it again is well suited to this idea of the emergency department, inpatient care, ambulatory care, and then the connections around them. And then, I love the way she talked earlier about stakeholders, right? Engaging and figuring out who's going to actually care about this problem, who needs to fix it, and how do we get them involved in this type of big idea for a mixed methods study. So the overall objectives, these are just basically the aims, kind of reworded a little bit, but we wanted to find the top and bottom performing EMS agencies in survival for out-of-hospital cardiac arrest, and we focused on the state of Michigan where we have much richer data, thanks to like Bob Newmar and some of the programs that he's put together, which I'll get into a little bit. And then to discover the best practices at those top performing EMS agencies, but then also to visit some of the bottom performing ones, and then to try to validate those factors, figure out what exactly is it. There have been a couple of attempts at doing this, like in Seattle, they have amazing results compared to the rest of the country, and they've actually put out some best practices, but a lot of them are like, live in the Pacific Northwest, be next to like a world-class medical center. So really hard to kind of figure out how you're going to do in like the Upper Peninsula. So that's kind of our sense of it. And again, we use what's called a sequential mixed methods approach. We actually figured out who were the best EMS agencies up front, right? So we did that using quantitative methods. Then, the idea is we want to go out and visit the ones that are the top and the bottom. And we have some unique ideas about how to do that in terms of engaging all of the different stakeholders. And then finally, to go back at a national level, again through like Dr. Newmar's connections, with the national CDC-sponsored registry called the CARES registry, and just figure out what's happening around the country. So again, it's not a new formula, but the real impact here is in how we're going to get all the stakeholders and communities involved. These are just some of the objectives, much more detailed within the grant. And then, this kind of gets at like, the how of what we're going to do here. We're going to use the Michigan CARES registry. The CARES registry is a statewide registry. It probably captures about 2/3 of the state population. It includes about 100 or so EMS agencies and about 90 hospitals. And it does participate with the National CARES Registry, so it has like a standard data collection form and reporting platform. And using this is how we're going to find out who are the top and bottom performing EMS agencies, and we have some really interesting preliminary data just about the variation across the state of Michigan itself. The second thing is, I think what is the real unique thing is trying to, and if we get this funded, this will be really interesting to see how we accomplish this, but it'd be exciting as well. Obviously we want to have some one-on-one interviews with key stakeholders, key leaders from each of those big buckets, right? So community leaders, first responder leaders like fire chiefs, et cetera, EMS leaders like MCA, control authority leaders, and then hospital leaders as well. But then we also want to do something really unique with focus groups where we start to include members of the community, other types of first responders that are on the ground, other types of hospital representatives. And I think that's going to be a really interesting and fascinating part about how we can start to discover what are these best practices that these diverse EMS agencies are using. Again, these are just some of the things that we've kind of started to think about, both from the focus group and key informant participants range. And then we want to come back to the same kind of, again, framework that Masheed's really been thinking a lot about, which is this acute care continuum approach. Again, thinking who are the individuals at all of these things that make a difference in terms of these really outstanding outcomes that some places are getting. So once we do that, we want to kind of not only just identify the best practices, but we want to kind of figure out why is it that some places are able to do this, the traditional types of barriers to delivering that type of superlative or really outstanding care. Our anticipation, our prior hypothesis here is that there are going to be individual strategies, but it's also going to be supportive organizational characteristics. Some of the things that, not only on the research side, but probably matter on the operational side, multidisciplinary teamwork, really strong leadership, effective communication, and then data feedback mechanisms in a lot of these systems. So, after doing all this, I think we do have this aim in there where we want to go out. We don't want to just learn about Michigan. We want to learn about the country, and we want to see how we can apply that. And I do think that that actually factors into one of the key aspects of this, which is, we have chosen from day one that we want to work with operational partners like the American Heart Association and other organizations around the country who are really vested in this problem, so that we can actually construct kind of best practices and then try to figure out a way to disseminate these to EMS agencies across the US. All right, so if we succeed, we haven't even gotten the money yet, but if we succeed, the idea is that we have these partners, we have these relationships. I think a lot of the reason why the grant was successful, to be honest, is because of, again, the work by a number of folks in the emergency department where they were able to show prior relationships with the state. And I can tell you, like talking with these folks, everybody is struggling with this problem. They want to know, they want to kind of work with us. This is, one of the biggest problems that they face and challenges, but it's also one of the things that gives them the strongest sense of purpose. They love these cases and they love the saves, and I think building on that is a really important part of it. But it's not a relationship you can just get after you get an NIH grant. It's one that you have to have years in terms of making before anything would ever work. All right, so I think I'll end with this slide, which is that the big picture thing that I can leave you with is that I think this is a great example of ACRU. Like I said, later on today, you're going to hear about all the great stories that happened in the past, the infrastructure that exists, what the ongoing projects are. This is actually a look, I think, into the future, which is really exciting. I think mixed methods should be a big part of what ACRU thinks about. And I'll end with this last part because I think it really serves as a competitive advantage. And I'll build on this, that this building with IHPI is really a super unique place, largely because it allows us to do things that just were never possible before. The very fact that, we can see each other during our grant writing sprint here, 2 or 3 times a week is just incredible. And that we can bring in Jane Foreman sits in this building, right? Eve Kerr sits in this building, Caroline Richardson. So it's just really amazing the talent that's around here that's just so easily accessible and allows for that kind of really multidisciplinary conversation and discussion. So thank you, and I'll end there.
Question. I'm Neil Winger from UCLA, and I get to see some of this from the inpatient perspective. And I see the intensivists and the CT surgeons and the perfusionists wringing their hands, wondering whether they made the right choice with some of their interventions when these out-of-hospital arrests are brought in. Is any part of this evaluation to in some way grade the likelihood of survival of these people in the field to help inform the decisions that get made post-ER?
So I think one of the conversations, and I can speak from what we've experienced with the in-hospital cardiac arrest study. So in that study, we're looking at in-hospital cardiac arrests, and you're absolutely right. In fact, more so in those settings because those people are already hospitalized and oftentimes already super sick, right? There's a reason why they had their cardiac arrest. In the out-of-hospital setting, oftentimes what happens is I think there's two things. One is people are usually, one of the definitions of sudden death is that there was no, predictable period of time before they were doing well and then suddenly had a sudden arrhythmic event. But one of the bigger issues is that and there are some states here, I think there's someone from OHSU, but, that have really pushed forward, physician orders for life, provider orders for life-sustaining treatments and then decisions after. But I think I'm going a little bit off tangent. To get back to your question, I think for us, one of the interesting conversations we've had is how different systems think about that. I can guarantee you there are some EMS agencies, like you said, that are probably thinking very deeply about, how do you determine life-sustaining therapies and decisions about that hospitalization. And there's probably some EMS agencies that haven't thought much about that at all. And the differences around that are probably going to make a big difference.
Right. And the reason is it okay to continue? Yeah. The reason I'm asking about this is standing in the cath lab, the conversation you hear is how long were they down, how long till CPR, how good was the bystander CPR, how long till return of circulation, how long till EMS was there. But you never hear which EMS agency picked them up, how good are they, which ER did they take them to, did they have to be transferred ER to ER? Those are the kinds of things I think that are going to be part of what you guys pick up. Maybe there's some comprehensive way to grade the likelihood of success beyond what they're seeing on the gurney to help inform these decisions, because they don't want to put people on ECMO that have extremely low probabilities of survival, but they're using hearsay information.
Yeah, no, I think one thing that you're getting at, and so I'm an interventional cardiologist, and you're absolutely right. At 2 a.m, everything you said is exactly what we think about, and we almost, a lot of times look for reasons where we're just is this going to happen or not? Bob Newmar can comment. He's starting a trial right now to look at enhanced CPR with ECMO guidance. Bob, do you have thoughts?
I can comment on that. And the challenge is that none of that information should inform your decision, because none of that information is a reliable predictor of outcome in any individual patient. If you look at populations of patients, you can look at their odds of surviving with good neurologic outcome, but in any one individual patient, it's been proven that none of those parameters alone or in combination reliably predict outcome in a patient that's been resuscitated. So in a general patient population, before they're resuscitated, before that falls back. But by the time they get to the cath lab, I bet most people in this room don't know patient resuscitated from out-of-hospital cardiac arrest makes it to hospital admission. What is their overall survival rate? What would you guess?
No idea.
Just give me a guess.
So they make it and they have return of circulation and they're in the cath lab.
Long enough to be admitted to the hospital. So of patients admitted to the hospital across the country,
a good 40%.
Yeah, it's 40%. But most intensivists will talk to families about the fact that this is a futile endeavor. And, you realize that once they make it to the ICU, their chance of survival is 40%. That's much higher than what people are telling families and what people think in their mind. And that's independent of any predictors beforehand. So I think there's a lot of misunderstanding and a lot of dogma out there about this patient population. So I think optimizing this system of care and getting more information out about how to do this in a way that is more rational.
Just to hit on that part is the nihilism that's around cardiac arrest. I think is something that and it's well founded. And a lot of times you hear about the story of the 90-year-old who's demented in a nursing home, and they come in, and we hang on to those stories time and time again. But I will say that, I mean, like in Seattle, for example, if you have VTVF and you're in like King County, right? I mean, it's like 60% survival rate. I mean, so when people, it's incredible, right? That someone drops down with a fatal arrhythmia and has more than a 50% chance of walking. It's just incredible. And so there's something clearly that places are doing better. I think we have to discover that. Our hope is that there's going to be really like generalizable and actionable things that we learn. It's not that there's some superstar nurse that's leading like the entire effort and like, she goes away, then the whole thing collapses, which you sometimes do learn, but like, those kinds of things are probably the better things that we're trying to experience.
Just highlight the other strength of this is, and what many people have sort of come to the conclusion is the system of care is really the most important thing, that if we really want to improve outcomes, we don't need a new drug or we don't need a new treatment. If you just take the system, take what the interventions that we have now and apply them in a robust way, that you could have dramatic impact on outcomes. And that's where places like Seattle and other places that have really worked hard to optimize their system of care all the way from the bystander response through the hospital prognostication are seeing outcomes that are almost twice as good as the rest of the
Excellent. Thank
Oh,
you so
no,
much,
thanks.
Brahmajee.
Thanks.